Hello everyone. Today we are going to discuss acute appendicitis. Appendicitis is an interesting disease because it affects a lot of people. Chances are you or someone you know has had appendicitis because it affects in your lifetime about 9% of men and about 7% of women. It can happen at any age, but it's most common between the ages of 10 and 30. But interestingly, the causes of appendicitis do actually change with age. The most common cause in adults is fecal obstruction. The most common cause in children is lymphoid hyperplasia leading to obstruction. And in the elderly, it's actually a neoplasm causing obstruction. All of these things make your pancreas angry and gives you the signs and symptoms of appendicitis. So if you suspect appendicitis in your patient, what should you be looking for? Well, on history, you should be asking about their pain pattern. Typically, these patients will have periumbilical pain that starts off pretty vague and colicky and becomes sharp and constant in the right lower quadrant. Typically, they'll have nausea and vomiting after pain, but importantly, this is only present in about 50% of patients. So on tests, you're likely to see this classic presentation, but in real life, you need to have a pretty high clinical suspicion for any patient that has a pattern of abdominal pain, even if it doesn't fit this one. You need to ask about past medical history, specifically surgeries, because you need to know if they've had their appendix out before. Having an appendectomy does not rule out appendicitis, but it should move it significantly low on your differential, and it's absolutely something you need to include in your presentation. On physical exam, you need to rule out peritoneal signs because these would indicate a surgical emergency, and you need to leave the room and get your attending immediately so they can examine them with you. For your GI exam, there's a lot of fun and special tests you can do for appendicitis. You can look for pain at McBurney's point, which is a point of maximal tenderness, 2/3 of a line drawn from the umbilicus to the anterior iliac spine. You can look for psoas sign, which is pain with hyperextension of the right leg. You can look for obturator sign, which is pain with internal rotation of a flexed right hip. And then you can look for Rovsing sign, which is right lower quadrant pain with palpation of the left lower quadrant. Finally, in pediatric patients, you can do the hop test, which is you ask a kid to hop and they refuse to do so because of pain. So the differential for appendicitis is pretty huge because it presents in lots of different pain patterns, and there's a whole lot of stuff and a whole lot of different systems that happen in your lower abdomen. So you need to include in your differential tons of things outside of the GI tract. So have a plan to organize your differential diagnosis. This is what helps me the most. You can pause the video here to look over all of these things, but the key thing you should be practicing with these things that have broad differentials like appendicitis is thinking about all the systems that are present in that area. So of course you have the GI system, but you also have OB-GYN considerations and you have GU considerations independent of your OB-GYN causes. Finally, you should include your extra abdominal stuff that you can throw into the differential for any abdominal complaint that we've talked about, like DKA, HUS in kids, and then just referred pain from other things that are happening in the body. As always, your diagnostic testing should reflect the differential diagnosis you've created. You should get a CBC, a CRP, BMP, LFTs, HCG to rule out pregnancy, a UA, and plus or minus guaiac stool testing. It's important to note that no single lab can confirm or rule out appendicitis, but in combination, a couple can. A CRP greater than 8 and a white blood cell count greater than 8 is highly suggestive, while a CRP less than 8 and a white blood cell count less than 10 is enough to effectively rule out patients for appendicitis as long as they have low pretest probability. So if they come in and they have all of those, like McBurney's point, psoas sign, obturator sign, Rovsing sign, all of those things are positive, and then their labs don't reflect that, that's not enough to rule out appendicitis because they have high pretest probability. So keep that in mind. All that epi-biostat stuff is important here. Now for imaging, there's a couple different options you can choose. Ultrasound is definitely a good option, particularly in young patients who have body habitus that is conducive to ultrasound and in pregnancy. It's important to note that ultrasound, like always, is operator dependent here, and this can be a tough ultrasound to capture. What you're looking for is you're looking for a blind ending tube that doesn't have peristalsis. And classically, you're just going to see a non-compressible structure that's greater than 6 millimeters. You might see some fluid around the appendix, but that's really not necessary for diagnosing appendicitis. The sensitivity here is pretty wide-ranging because it is operator dependent, 66 to 100%. And the specificity is actually pretty good as long as you've successfully identified the appendix, 83 to 96%. For CT, you're looking for an abdominal, or you're just looking for an abnormal appendix or an appendix that has a diameter greater than 6 millimeters. Sensitivity for this is improved. It's 90 to 100%, and specificity is 91 to 99%. One thing you want to think about here is considering giving oral or IV contrast. At a lot of academic institutions, you're going to probably be doing this. For MRI, this is good in pregnant patients, but just keep in mind MRIs are slow and you often don't have access to them in the emergency department. Your diagnostic criteria on MRI are an enlarged appendix greater than 7 millimeters and a wall greater than 2 millimeters. Sensitivity for this is extremely high, 97 to 100%, and specificity is also really good at 92 to 98%. Because we're emergency medicine doctors and we love point of care ultrasound because we can do it at the bedside, let's take a quick look at an ultrasound that shows us what appendicitis looks like. Here we see the appendix. It is this blind ending tubular structure, and we're looking at the long axis. And you want to measure this diameter to see if it's greater than 6 millimeters. It's important to note that the long axis is not always the best view to measure the diameter because you might not actually be at the thickest part, so you might be giving yourself an abnormally thin appendix. So if you can get the appendix in short axis, this will give you a more reliable result for the actual diameter. Management of appendicitis can be a little tricky and is an area of ongoing research, but there's a couple things you're going to do every time. You're going to make your patient MPO and start them on IV fluids because these patients might be going to surgery. Then you're going to give them pain control with morphine 0.1 milligrams per kilogram and nausea control with Zofran 4 milligrams IV. If they are uncomplicated, if they have uncomplicated appendicitis, you are going to get a surgery consult, and they are most likely going to be in the driver's seat for making these decisions, but the decision they're going to be making is for antibiotics versus surgery with antibiotics. This is obviously up to debate and still up to ongoing research, but there's enough evidence that says you can safely treat uncomplicated appendicitis with antibiotics alone. And the antibiotics you would be considering are cefoxitin 2 grams IV QID or a combination of Cipro and metronidazole. However, if surgery does want to operate, they are likely going to start antibiotics within 1 hour of surgery. Perforated appendicitis, however, gets antibiotics no matter what. There's lots of combinations, but one of cefepime and metronidazole is pretty common. The disposition for these patients, again, is going to be determined most likely by surgery. They are possibly going to go to the OR or be made inpatient for administration of their IV antibiotics. There is a rare subset of patients that's actually safe to discharge home. If you think your patient falls in this group of patients who's safe to discharge home, there's a couple things to keep in mind. Primarily, most of the antibiotic regimens you're going to see are IV. If you are suggesting your plan to your attending, absolutely do not suggest antibiotics that have to be given IV if you want to discharge them home. These are two separate, uncompatible things, and it will get you in trouble, and we don't want that. So if you're going to discharge them home, make sure all their meds are PO, and make sure you give them really, really good return precautions, because if their pain gets worse or just never goes away, if they start to develop a high fever or just have persistent nausea and vomiting where they think they might be getting dehydrated or it just won't go away, these are all reasons to come back to the emergency room. Now it's time for some fast facts and practice pearls about acute appendicitis. Like we discussed earlier, white blood cell count doesn't really mean anything on its own in the setting of acute appendicitis. Next up, you should be doing a pelvic exam on patients who have a vagina and a uterus because a lot of these things are on your differential, and a pelvic exam is one of the only ways to assess them. However, cervical motion tenderness does not exclude appendicitis. These two things can exist together. Then, post-surgical patients can get stump appendicitis. This is rare, and we sort of touched on it whenever assessing your patient's past surgical history, but this is something you should always keep in the back of your mind. Just because they've had their appendix out doesn't mean it can't still be appendicitis. Finally, patients of extreme age often have atypical presentations. They can have worse complications and worse outcomes. This is pretty much true across the board, but it's true in the setting of appendicitis as well. Acute appendicitis is an interesting disease because it's something we've all had probably at least a little bit of exposure to on the patient side. On the physician side, however, it can be a pretty scary thing because it comes with a large differential diagnosis and it requires you to have a high clinical suspicion because it's really a don't miss disease. You get in a lot of trouble and can even have like some legal trouble if you miss appendicitis. So it's something you always want to be on the lookout for. So I would encourage you to, like all of these things, do a little bit more reading about it and get comfortable with how it is managed. I used these resources. I think they're great at looking for imaging and how to really get a good plan for how you're going to address patients who you think might have appendicitis. As always, thanks for listening.